students? Please let me know if you can hear me. So that we start our session. I'm waiting for you all. Okay, so I welcome you all to another INICET PYQ masterclass for the subject of oral and maxillofacial surgery. So we'll be discussing a few more previous year's questions today and some very interesting ones. And along with some very interesting questions, I'll also be giving you some important pointers that you need to add in your notes, that you need to remember, so that any question asked in the future or any potential question you all can answer easily. Good evening, Shweta. So again, my request to all of you is I'm going to read out the question along with all the 4 options. Please answer. Please make it an interactive session. The more you interact, the better you remember things in your exam. So please answer the questions in the live chat box, and please let me know the question number also along with your answers so that I'm aware what question you have answered. Good evening, Reena. So let us start. Okay, so all of you have to answer in the comment section today. And let's start with question number 1. What is the ideal treatment for an edentulous mandibular fracture classified as Lure class 2? Your options are A. Circummandibular wiring using the patient's denture, B. Transmucosal load-bearing plate, C. Submucosal load-sharing plate, and D. Mandibular splinting with arch bars. So what would be the answer over here? Even if you have not heard or read about Lure 2 classification, just try to answer. Just try to answer on the basis of that it's an edentulous mandible, and edentulous mandible will most likely be atrophic. So answer as according to that. What would be the answer here? Anyone who wants to answer, who wishes to attempt this question? Otherwise, we will see what is the question. Now, whenever you get such a question, when you have not heard anything about such a question, okay, but there is some information in the question that you know, all right. So it says treatment of an edentulous mandibular fracture classified as Lure 2. If you know Lure's classification, well and good. If you do not know Lure's classification, you have to answer on the basis of your knowledge of an atrophic mandible. What is Lure's classification? I'll tell you in the subsequent slides. Now, let's look at each of the options one by one. A is a circummandibular wiring using the patient's denture. No, this is not the... Good evening, Ritz. Very good evening. Coming to option number A, circummandibular wiring using patient's denture. I have told in the class also, we never prefer the patient's denture for treatment of edentulous mandibular fracture, because this option of ridges is a continuous process and the denture tends to become loose over time. It tends to lose its stability and retention. Alright, so option A is ruled out. Okay. Now option B is transmucosal load bearing plate. Okay, transmucosal load bearing plate. Now this kind of looks familiar. Load bearing plate. Yes, you can use a load bearing plate in a atrophic mandible. What are your load bearing plates? Those are your reconstruction plates. So I've told that in the class also. Okay. Option C, submucosal load sharing plate. Now, load sharing plate has no role to play in a atrophic mandible. Okay. And submucosal, that means you are reflecting the mucoperiosteal flap from the bone. As it is, the bone is atrophic. Vascularity with age gets compromised. If you raise a mucoperiosteal flap, you are further insulting the periosteum, stripping the periosteum from the bone. So it is going to be problematic for the patient. So submucosal and load sharing plate you definitely do not use in an atrophic mandible. Alright. Now the next option is mandibular splinting with arch bars. You cannot put an arch bar in an edentulous patient. You need a dentate patient to put an arch bar. So obviously this is not possible. So transmucosal load bearing plate is the correct answer. Okay. This is the correct answer. Alright, so even if you do not know what is Lure's classification, you can attempt based on your common sense and whatever has been taught to you in the class. Okay, now let us see what is Lure's classification. This is important and this can be asked further in your exam. So this basically Lure gave a classification based on the remaining ridge height of the edentulous mandible. Alright, so this is on the basis of remaining ridge height. Remaining alveolar ridge height. Okay. So what did Lure say? He said if the remaining height of the mandible is between 16 to 20 mm, then it is classified as class 1. If the remaining height of the mandible is between 11 to 15 mm, then it is classified as class 2, and height of 10 mm or less than 10 mm is classified as class 3. So class 3 becomes a severely resorbed ridge or a very poor ridge. Alright. Now, treatment of edentulous mandible as per Lure's classification. So we have just now seen the classification and the bone height. So for class 1, he said you can use a load sharing mini plate. Those are your 2 mm profile or 2 mm thick plates. Alright, in a class 1 you can still use mini plates. Fine. In class 2, the bone height is reduced, so you need a load bearing reconstruction plate. Okay. And similarly in class 3, you need a rigid load bearing reconstruction plate via extraoral approach. Alright, just give me a moment, I'll explain this. So your reconstruction plates are thicker. They can be 2.4, 2.7 mm. Alright, so here also. Class 2 and class 3 will be reconstruction plates, which are thicker, which are load bearing. Okay, and not load sharing. Now so this basically Lure's classification and the treatment modalities according to the Lure's classification you don't find in books, you find them in articles. So this information that I'm telling you has been picked from articles. I have simplified the information for you all. Okay, now there is something known as an intraoral approach for edentulous mandible and extraoral approach. Now please understand, whenever there is a edentulous mandible fracture, especially bilateral edentulous mandible fracture, you are supposed to give a long span plate from angle to angle. Okay, because it has to do the function of the bone, it has to bear all the functional stresses. So a long span plate is given, and a reconstruction plate is usually put across at the lower border. There is another question on reconstruction plates further in the session. I'll explain you then. Okay, now there is a difference of opinion. Few authors say if we go intraorally, we can put a reconstruction plate, a long span plate, but it leads to too much of retraction of the soft tissue, causing a decrease in vascularity and causing more traction injuries or retraction injuries to the patient. And some authors say it is better if we give an extraoral incision here, all right, in the submandibular region, extending across, and this causes less traction injuries, gives better exposure, and our plating is better. So you can do intraoral also, you can do extraoral also. No study has found out that intraoral is better or extraoral is better. It depends on author to author, clinician to clinician. Okay. Now there is this flow chart which I want you to remember. This is again taken from an article. It is not taken from any book. Depending on degree of atrophy, if there is mild atrophy, that is Lewer's class 1, you can use a 2 mm locking plate. That is a mini plate. Okay. Fine. If there is a, you can also, in mild atrophy, you can also use a 2.4 mm locking plate. It depends on the clinical scenario. Now, if there is severe atrophy, that is class 2 or class 3, you can use a 2.4 mm locking plate. And if there is a non-consolidated fracture, that means a non-union fracture scenario, or there is bone loss, or there is a discontinuity defect, then you have to use a bone graft and also secure it with the help of a 2.4 mm locking plate. So next potential question in your INI can be Lewer's class 2 or class 3, and bone graft can be given in one of the options. So please remember these things. Okay, you have to remember these things. Fine. Is it clear, everyone? Let's go on to the next question. Okay. Question 2. An 8-year-old boy comes with bilateral TMJ ankylosis. His parents give history of excessive snoring, continuous waking in the night with daytime somnolence. What will be the treatment? A. Gap arthroplasty. B. Costochondral graft. C. Mandibular distraction. D. Wait and watch till child attains adulthood. What would be the answer over here? Please answer. Students watching live, please try to answer this question. Okay. Others also please answer. Okay. Now let us see the question. Also note whatever things I'm circling or highlighting in the question are your keywords. 8-year-old boy comes with bilateral TMJ ankylosis. Parents give history of excessive snoring, continuous waking in the night with daytime somnolence is daytime sleepiness. All right, or falling asleep during the day while doing routine activities, falling asleep while attending school, falling asleep while watching TV, while eating food. All right, so that is called as daytime somnolence. What will be the now if you look at the question, it is trying to tell you that there is severe respiratory compromise. So you need to relieve this first. You need to take care of the respiratory aspect first. So in this case, mandibular distraction is to be done first. Okay. This is your answer here. You can do a gap arthroplasty. You can do a costochondral grafting. Yes, that is the treatment plan, but that is not going to relieve your airway symptoms. And wait and watch will not help. Patient is going to go into acute respiratory problems. So, gap arthroplasty, costochondral graft are not the priority. The priority is to bring relief to the airway. Okay. Now, please remember this table. So, if there is ankylosis with no airway compromise, you have to release the ankylosis first, do a interpositional arthroplasty, followed by reconstruction with costochondral graft and post-operative physiotherapy. But if there is ankylosis with airway compromise, and in airway compromise, your signs and symptoms are obstructive sleep apnea, snoring, somnolence. Okay, so you do a distraction first, which improves the airway, corrects the micrognathia, release of ankylosis, followed by release of ankylosis and costochondral grafting, and followed by aggressive physiotherapy. So you have to improve airway and correct micrognathia. Okay, again, there is this based on clinician to clinician, especially when there is an airway compromise. Some say do a distraction first, some say do distraction plus ankylosis release simultaneously. So both schools of thoughts are correct. You can do the distraction first, lengthen the mandible, open up the airway, followed by release of ankylosis. Some surgeons believe that you do the distraction and release of ankylosis simultaneously. So again, this sort of information is found in articles. Please keep that in mind. Okay. Now, Deepa, I hope you have understood. Please let me know. Coming to question number 3. A 10 years old child is brought to the emergency department after a road traffic accident. He exhibits persistent bradycardia and hypovolemia. On CT, there is herniation of orbital contents. What is the likely diagnosis? Option A, white eye syndrome. Option B, skull base fracture. Option C, herniation of brain. Option D, hypovolemic shock. So what would be the answer to question number 3? Please let me know. Okay, very good, Deepa. What would be the answer to question number 3? Yes, very good. Others also, please answer. Anyone else who wants to answer? So let's understand the question. 10-year-old child. So it's a pediatric patient brought to emergency department after road traffic accident. So there's history of trauma. Exhibits persistent bradycardia. What is persistent bradycardia? Decreased heart rate. And hypovolemia. What is hypovolemia? Fall in blood pressure. On CT, there is herniation of orbital contents. What is the likely diagnosis? So this is pointing towards a orbital blowout fracture or a orbital floor fracture. Orbital blowout fracture or orbital floor fracture, and this is indicating towards a trap door fracture. That means the muscle, the inferior rectus muscle has got entrapped in between the fracture segments. Okay. Now there's something known as a white eye syndrome. Alright, and it is associated with orbital blowout fractures or a trapdoor fracture. Okay, so if this kind of a patient walks into you in the emergency room, there will be no clinical signs of orbital floor fracture or injury. if you will just look at the child. All right. Symptom is what the patient tells you. Signs is what you identify. If you just look at the child, so there will be no orbital injury signs, no edema, no circumorbital edema, no circumorbital ecchymosis. All right. There would be no abrasion, nothing. All right. So no circumorbital edema or ecchymosis. Now, on examination, you can find out that patient has restriction in upward gaze. Right? Patient has restriction in upward gaze. Alright, and then patient can have a trigemino cardiac reflex, also known as a oculocardiac reflex. Now this is a triad of bradycardia, hypotension, and nausea, vomiting. Right? So this all comprises of your white eye syndrome. So when such a scenario is present, it becomes very necessary and it becomes an emergency to release that entrapped muscle. Alright, because that entrapped muscle will, once you release it, will reverse the oculocardiac reflex. Fine. So please remember what is a white eye syndrome. So the correct answer here is a white eye syndrome. Fine. Correct answer here is a white eye syndrome. Now, coming to question number 4. When using reconstruction plate for resection defect, which of these is true? Coming to your options. A, should not be covered by soft tissue due to risk of exteriorization. B, minimum of 2 screws should be used on both sides. C, locking screws should be used. D, the reconstruction plate should be fixed between the superior and inferior borders. So what would be the answer here? I want all of you to answer, even if you do not know the answer, please answer. I'm waiting for the answers. Okay. Others? Please answer in the comment section. Others also please answer. Don't be afraid of tough questions. Okay. Now, there they're asking you regarding reconstruction plates. Right? They're asking you to identify the correct statement. Alright. Before coming on to the correct answer, I want to explain you all something. Okay. Reconstruction plates are rigid, load bearing, non-compression osteosynthesis. Alright. We have discussed this in my class also. I have given the classification of fixation devices. Okay. You can go and revise that. Now it is mostly used with bicortical locking screws. It can be used with non-locking screws also, but to give it more stability and rigidity, it is used with bicortical locking screws. Now, and what is the advantage of bicortical locking screws? Rigidity increases and chances of infection and hardware failure decrease. Fine. Now, I am drawing a scenario for you. Please try to remember this in your exam and you will not have any problems. Okay. Let us assume there is a mandible with a continuity defect. Okay. There is a mandible with a continuity. You have this kind of a scenario. Now, you remember I told you that we do the plating at the inferior border. Now I want you to understand very carefully. This is a continuity defect. I have used a reconstruction plate for reconstruction in the middle portion, alright, where there is no bony anchorage for the plate. In that area, what do? Is we give a good soft tissue cover to the plate. Alright, first we will do the muscle layer closure, then we will do the submucosal layer closure, finally followed by mucosal layer closure. So we give a very good layer by layer closure. This is done to prevent exposure of the plate after in the post-op period, after a few months, few years, whatsoever. Okay. So good soft tissue cover to prevent exposure of the plate or exteriorization of the plate in the future. Alright, this is one principle of reconstruction plate. Now, if you see the reconstruction plate on the bony ends, I have drawn 3 screws. Alright, so the principle for reconstruction plate is minimum of 3 screws on each side. Minimum of 3 screws on each side. Okay. Now it is fixed at the lower border. So bicortical, why it is fixed at the lower border? Because bicortical screws, if the patient is dentulous patient, alright, suppose in a comminuted fracture, or if a dentulous patient is having a continuity defect, the bicortical screws will go and hit the roots of teeth, causing devitalization of teeth. So reconstruction plates are preferably placed in the lower zone. Okay, so these are 2-3 points that you have to remember with reconstruction plates. Now this is how a reconstruction plate looks. Alright, you also have angled plates, you have straight plates. So I'm going to zoom out. This one is a recon plate. Okay, let me change the pen color. This one is a recon plate. Alright, and this one is a mini plate. Okay. By looking at it, you can make out that reconstruction plate is very, very robust. Okay. So, one way is to plate like this. Alright. The other way is to plate at the inferior border like this. Alright. There's another way to do the plating at the inferior border. One is at the lower aspect, laterally, buccally, at the lower aspect, and one is actually to plate it at the inferior border. Both are correct. It depends on surgeon's preference. Alright. So now let's get back to our options, and they are asking you to identify the correct option. Okay. So it should not be covered by soft tissue due to the risk of exteriorization. This is false. Minimum of 2 screws should be used on both sides. No, minimum of 3 screws should be used on both sides. Locking screws should be used. Yes, this is correct. The reconstruction plate should be fixed between the superior and inferior border. No, it should be preferably always fixed at the inferior border. So locking screw should be used. This is the correct answer. All right. Fine. Is it correct? Is it understood by everyone? Utkarsh, Deepa, please let me know in the comment section if you have understood this question and the concept of reconstruction plates. Okay, coming to question number 5. Identify the image given below. Option A says oral preformed tube. Option B says nasal preformed tube. Option C says PVC endotracheal tube. Option D is reinforced endotracheal tube. Please answer, all of you please answer this question. I have shown the visuals of such a question in my previous session. So please answer, all of you. What is exteriorization? Okay, Utkarsh, what is exteriorization is basically, you remember, okay, I'll just to explain this area. If you see this area, the one that I'm shading in orange, in this area you just have the plate. You don't have any bone to anchor the plate. Okay, now in this area, if you don't give a good soft tissue cover, if you don't do a good layer by layer closure, all right, your soft tissue closure should be robust, muscle followed by submucosa followed by mucosa. All right, if you just cover it with soft tissue and just close the mucosa, after some time what will happen, the plate will start popping up from beneath the soft tissue. It will get exposed. All right, so the plate will become visible in the oral cavity. That is known as, when the plate comes in contact with the external environment or intraorally it gets exposed, that is known as exteriorization or exposure of the plate. Okay, so to prevent this, we give a good soft tissue cover. I hope your doubt is clear, Utkarsh. Please let me know, and please all of you answer this question. Question number 5. In my last session only, we have seen such kind of visuals. Okay, others also please answer. Whosoever are live. Okay, very good, Utkarsh. Okay, I have another answer. Fine. So this is a nasal preformed tube or a North Pole RA. Please understand, I am going to take up intubation in the predictor series. Okay, so don't worry, before going for your exams I'm going to revise intubation with all of you. All right, so this is basically a North Pole RA, the one given in the picture over here. Okay, now how do you identify, especially when you don't have the patient with you? How do you identify? So this is the cuffed end, this will go in the trachea. Now just imagine, I told you in the last session also, you will have to imagine that if this end is going into the trachea, how is this bending? This is bending towards the head end. Okay, alright, and head end is known as north. So this is a north pole RA, which is inserted via the nasal route. Alright, now let us imagine if you have this similar tube, but the bend is towards this side. Alright, there is a cuff over here. Okay, so this end will go into the trachea. You have to imagine the patient, that you are putting this in the patient. You have to use your visual imagination at the exam time. Alright, so if you have a tube which has a bend towards this side, okay, you have to imagine that this is going to the trachea, so the bend is towards the foot end of the patient or the south pole of the patient. So this will be inserted orally and this becomes a south pole RA. Alright. So N for north, N for nasal, and the south is oral. Okay. This is how you have to remember. Understood, Utkarsh? Is it clear? Deepa, is it clear? Okay, there is nothing known as a reinforced endotracheal tube. There is something known as a flexometallic endotracheal tube. We'll see the visual in the predictor series. We'll be doing one predictor series before you all go for your exams. Okay. Okay. Let's move ahead. Question 6. In which type of suture material is microbial transmission and wicking effect evident? A. Synthetic monofilament, B. Plain gut, C. Teflon, or D. Silk suture. Okay. Answer to question number 5. Please answer, everyone. So, it is asking the wicking effect. Alright. The answer here is silk suture. Fine. Now, what is wicking effect? Wicking effect is migration or percolation of oral fluids along with bacteria through the suture tract. Okay. And this increases the risk of infection. Fine. And it is seen with, please remember, it is seen with multifilamentous sutures. It is seen with multifilamentous sutures. So your examples are picral and polyglycolic acid, polyester, which is also known as epibond, and silk. Okay. So these are your absorbable and these are your non-absorbable. Okay. So please remember, wicking effect will always be seen with multifilamentous sutures. Okay. Let's move on to the next question. Question number 7. What is the preferred surgical treatment approach for an aminoblastoma extending to the lower border of mandible? A. Enucleation, B. Resection and reconstruction, C. Marsupialization, D. En bloc resection. What would be the answer here? I have discussed this question before also, I think in my MCQ edition. So please let me know the answer. I'll wait for all of you to answer. Very good, Deepa. Please answer. Rest all. Now, I'll explain again. So, there is an ameloblastoma extending to the lower border of mandible. Alright, extending to or involving the lower border of the mandible. That means the lower border is close. So, now let us suppose if this is the mandible, okay, and there is an ameloblastoma which is almost reaching the lower border. Okay. Now you have to take 1.5 centimeters of margin all around. Okay. 1.5, 1.5, 1.5 and 1.5. So while you will be taking the inferior margin, you will have to take the inferior border along with you. Or okay, you will have to take the inferior border in the specimen. So what will result? It will be a resection with continuity defect, which is also known as segmental resection. And once you have a continuity defect, you need to reconstruct it. Alright. So you will end up doing a segmental resection. So please remember the keywords: extending to the lower border, or reaching up till the inferior border, or involving the inferior border. To take margins, you have to sacrifice the inferior border. Hence, the correct answer is resection and reconstruction. Okay. En bloc resection is marginal resection. Alright. En bloc resection is marginal resection. Fine. And enucleation and marsupialization have no role in ameloblastoma. So they are not the correct answer. Okay. Is it clear, Deepa, Utkarsh? I hope this is clear to both of you. Please revise various types of resection from the notes. Okay. Now coming to the next question, it says hyphema represents A, change in position of the globe, B, blood in anterior chamber, C, blood in vitreous, D, retinal hemorrhage. What is the correct answer here? A little difficult question, but please try to attempt. So hyphema represents blood in anterior chamber. It is basically the accumulation of blood between cornea and iris. Okay. So in my predictor series, I will also be doing ophthalmological complications of maxillofacial injuries. We'll just see a few terminologies. Only that much is required at our level. Rest all comes under the scope of ophthalmology. Fine. So just remember, it is blood in anterior chamber. So accumulation of blood between cornea and iris. Alright, is it clear to everyone? Utkarsh, HS, Deepa. Fine, let's move ahead. Question 9. Which of the following is most commonly used local anesthetic combination in dentistry? A, 0.5% lignocaine with 1:1000 adrenaline. B, 2% lignocaine with 1:1000 adrenaline. C, 0.5% lignocaine. D, 2% lignocaine. What would be the answer to question number 9? Okay, very good, HS. Rest Also, I hope all of you have understood. Others? Others also please answer. Okay. So most commonly used local anesthetic combination in dentistry. Now, please don't get confused. They have used the word combination in the question to trick you. Okay. 1:1000 adrenaline is used for anaphylactic shock. Or a patient who is in cardiac arrest. Fine. It is not routinely administered in the dental setup. Fine. So, adrenaline strength used in dentistry is 1:80,000 or 1:1 lakh or 1:2 lakhs. Fine. This is the strength of adrenaline used in dentistry. So, option A is not correct. Option B is not correct. Option C, 0.5% lignocaine is a very weak anesthetic. So it will not give any anesthesia or analgesia. Alright. So this is also not used. The correct answer is 2% lignocaine. Now 2% lignocaine no doubt is short acting and it cannot be used in long procedures, but amongst the given option the best that you can pick is 2% lignocaine. Okay, fine. Is it understood? Utkarsh and Deepa, have you understood? Please let me know, then we'll move ahead. Coming to question number 10. Which of the following is the confirmatory test for cerebrospinal fluid or CSF rhinorrhea? Your options are A. Tau protein, B. Persistent nasal leak, C. Halo sign, D. MRI. Please answer this question. It is asking you the confirmatory test. Please pay attention. Confirmatory test. Very good. Very nice. So tau protein is the correct answer, or beta 2 transferrin, also known as beta 2 transferrin or tau protein. Fine. Halo sign is seen clinically. It is a clinical sign. It is not a confirmatory test. Okay. Now, persistent nasal leak can be anything. It can be CSF, it can be nasal secretions. Okay. So, that is ruled out. Halo sign is correct in relation to CSF, but it is not the confirmatory test. It is a clinical sign, and MRI is not going to detect a CSF leak. Fine. Is it clear, everyone? So some very important points. The most common cause of CSF rhinorrhea is cribriform plate fracture. Cribriform plate fracture. So, like I told you, tramline pattern on the face and halo or ring sign on cloth. CSF never starches cloth. So these are your differentiating points. Alright, these are your differentiating points. They can be mentioned in the question. Then if you compare the CSF to blood or serum, very important, it contains less glucose and more protein. Alright. So in comparison to serum, CSF has less glucose, and in comparison to serum, it has higher protein. And the specific diagnostic tests are beta 2 transferrin or tau protein. Okay. So you need to remember all of this. These are very important points in relation to CSF rhinorrhea. Now coming to question number 11. For a patient with displaced linear fracture in the fracture of the mandible is treated with closed reduction, what is the ideal duration of intermaxillary fixation or IMF? So what would be the correct answer over here? Option A 2 weeks, B 4 weeks, C 12 weeks, D 8 weeks. It is a simple question. Come on, all of you please answer. Very good, Deepa. Question number 11. Okay. So, fine. Now, before we answer this question, let us see the rules of IMF. I have taught this many times in my previous MCQ editions also, in class also. Alright, so there are certain rules according to which the duration of IMF is decided. So if there is a young adult with fracture of the angle to receive early treatment in which tooth has been removed from fracture line, you do 3 weeks of IMF. Okay. Young adult, fracture of angle, early treatment, tooth removed from fracture line. You have to remember these 4 things. Young adult, angle fracture, early treatment, tooth extracted. Okay. You do 3 weeks of immobilization. Alright, now this 3 is your baseline. Whatever addition, subtraction you do it over 3. Okay. So if there is a tooth retained in fracture line, if you retain a tooth to the fracture line, you will add 1 week to 3 weeks. Okay. If there is fracture at the symphysis, you will add 1 week to 3 weeks. Fine. If the patient is 40 years or more, you will add 1 to 2 weeks. Now please listen. If the patient is 40 to 50, no comorbidities, you will add 1 week. If the patient is more than 50, you will add 2 weeks. Or if the patient is 40 to 50 plus comorbidities, you will add 2 weeks. Okay. So if the age is more, then the duration of IMF increases, or if there is a comorbidity, then the duration of IMF increases. Okay. And if it's a child, you will subtract 1 week from 3 weeks. Okay. Now let's see. For a patient with a displaced linear fracture of the mandible, treated with closed reduction. Now here they have not given you any information regarding the site, regarding the age of the patient, whether tooth was removed or tooth was retained, or whether the patient received early treatment or delayed treatment. You have not received any information. It is just saying a displaced linear fracture. So 3 weeks is your baseline. Alright, 3 weeks is your baseline. You will search for an option which is closest to 3 weeks. Maybe you can add 1 week only for the displacement. Okay, so you will stick close to your baseline because no information has been provided to you in the question. So the best answer here is 4 weeks. Okay, the best answer here is 4 weeks. Is it understood? Deepa, Utkarsh, have you understood? So 12 weeks is a very long time for IMF. It is very cumbersome for the patient. Alright, 12 weeks is 3 months. You cannot put a patient under IMF for 3 months. Okay. So this is how you are supposed to attempt your questions. Now, coming to question number 12. A patient with a total joint replacement surgery reports for dental extraction 2 years later. Which of the following is recommended? A. Clindamycin 600 mg 1 hour before the procedure. B. Amoxicillin 2 grams 2 hours before the procedure. No prophylaxis needed is option C. And D. Cefazolin 1 gram 1 day before the procedure. So what would be the answer over here? Please let me know. More answers, please. So there is no prophylaxis needed. Okay. This is the correct answer. No prophylaxis needed. So whether they have mentioned any joint replacement, hip replacement, knee replacement, TMJ replacement. For joint replacements, you do not need to give any prophylaxis. Now, in the next slide, there is a table for prophylaxis. This is a table which is there in your books also, but just take a screenshot of this over here so that you can quickly revise while reading. So all of you have got this answer correct. Very good. So high risk prophylaxis is when the prophylaxis is required. So that is a high risk patient. You definitely require prophylaxis in such patient. You have to administer prophylaxis. Prosthetic heart valve, previous history of bacterial endocarditis, major congenital defects such as Pallet's tetralogy, transposition of great vessels, and single ventricle. Okay. or surgically constructed shunts or conduits. So a very important example is you create a AV shunt for a dialysis patient. So such patients who have surgically constructed shunts, all right, or surgically constructed conduits like a AV shunt. So in those patients also prophylaxis is very important because they fall in the high risk category. Okay. Now coming to the moderate risk category where also prophylaxis has to be given: rheumatic heart disease with valve dysfunction, cardiomyopathy with valve dysfunction, mitral valve prolapse with regurgitation, and most of the congenital defects like congenital heart defects especially. Okay, so they've come under moderate risk. Now coming to low risk where prophylaxis is not required and it need not be given. So rheumatic heart disease without valve issues, cardiomyopathy without valve defect, hypertensive heart disease, coronary artery bypass graft. That means if a patient has previously undergone a coronary artery bypass graft, patients with treated atrial or ventricular defects with no problems in the past 6 months, patients having pacemakers, patients having isolated atrial septal defects, and patients with physiological murmurs. And all the rest categories of patients, you do not need to give prophylaxis. You just need to remember column 1 and column 2. Rest all fall in the no prophylaxis required category. Okay. So please remember this chart, very important. Coming on to question 13. Which of the following statements is not true about conditions shown in the image? A. It can be seen in minor salivary glands. B. It is most commonly found in the ducts of submandibular salivary glands as the duct is short and straight and the secretion is more serous. It is not commonly seen in parotid gland. It is most commonly associated with recurrent swelling and pain during meals. What would be the correct answer here? Quickly let me know, all of you. Others also please answer. Okay, let's see. So what do you see in the image? You see a stone, right, which is present at the duct orifice. So this is a cyalolith. Okay, the question is asking you to identify the correct statement regarding a cyalolith. Fine. So it can be seen in minor salivary glands. Yes, this is correct. Salivary stones can be present in major and minor salivary glands both. Okay. It is most commonly found in the ducts of the submandibular salivary gland as the duct is short and straight and the secretion is more serous. It is most commonly found in ducts of submandibular salivary gland. This part of the statement is correct. Okay? But the duct of submandibular gland is long and tortuous. It is not short and straight. Also, the secretion of the submandibular salivary gland is more mucus. Alright? It is not more serous. It is more mucus. Fine. So, option B is not true. C. It is not commonly seen in parotid gland. Yes, salivary stones are not very common in parotid gland. And D. It is most commonly associated with recurrent swelling and pain during meals. So, whenever a patient who is suffering from cyalolithiasis will always complain of pain and swelling during meals, because when the patient is eating food, there will be stimulated production of saliva, and the saliva will get accumulated in the duct, will not flow out from the duct due to obstruction by the sialolith. So associated pain and swelling during meals is very common during sialolithiasis. So option B is the correct answer. This is the statement which is not true. Fine. Now coming on to a few important points. So submandibular duct is known as Wharton's duct. It is long and tortuous. Saliva is mucus, like I told you. These factors along with gravity contribute to the highest incidence of stones in submandibular gland. Okay. Now coming on to the treatment, as per the whatever treatment part comes under oral surgery. So the treatment according to the location of the sialolith. So if the stone is present in the terminal portion of the duct or present near the orifice, then the treatment is milking of the gland. Okay. If the stone is present towards the posterior aspect of duct, alright, then you give an incision of the over the stone. You palpate the stone. You give a longitudinal incision where you can feel the stone. You give a longitudinal incision on the duct, and you evert the duct margins, like how you in marsupialization, you suture it to the adjacent mucosa, you evert the duct margins and suture it to the adjacent mucosa. Okay. If the stone is present within the gland, you have to remove the gland. Okay. And the process to remove a sialolith is known as lithotripsy or sialolithotripsy. Okay. Coming to question number 14, last question for the session. At what dose is lignocaine toxicity observed? A 7 milligrams, B 2 milligrams, C 10 milligram per kg, D 5 milligram per kg. So what is the correct answer over here? Please let me know. Questions on toxicity have been asked repeatedly every year, whether in NEET or INI. So I want all of you to answer. I keep on stressing on toxicity of LA in all my sessions. Please answer, all of you. Question 14. Okay. Let's go through these tables again. I have put it because I know that it is difficult to remember. Now, if you see various CNS features and LA levels, so 0.05 to 4 microgram per ml is anticonvulsant action. Okay. 4 to 7 microgram per ml is the talkative or slurring of speech. So this is when toxicity is starting. This is the therapeutic action. Okay. 7.5 to 10 microgram per ml, there is generalized tonic-clonic seizures. More than 10 microgram per ml is severe CNS depression and collapse. Patient has collapsed also at 10 microgram per ml. Now the second table says various CVS features and LA levels. 1.5 to 5 microgram per ml is anti-arrhythmic action. So this is therapeutic. 5 to 10 microgram per ml CVS depression evident on ECG. So ECG changes start. This is when toxicity has started showing its effects. And more than 10 microgram per ml CVS has collapsed. Patient has also collapsed. Read the question again and answer again, all of you. At what dose is lignocaine toxicity observed? Not when patient has collapsed. Question is not asking when patient collapses. When when it is observed, that means the first sign of toxicity is seen at which level? Now please answer this question before we wind up the session. All of you should get this correct. And please paste these toxicity levels in front of your table, on your desk, in your book, wherever you're reading. Revise toxicity levels every day. I'm telling you, one question from this, either an INI or NEET, is confirmed. Please answer in the comments, all of you. So 427 microgram per ml. There the unit was microgram per ml. Here they have given mg per kg. So slurring of speech. Yes, please answer, all of you. I'm waiting for your answer. And at 5 microgram per ml, 5 to 10 especially, there are ECG changes. So what is common? 5. So toxicity, first sign symptom of toxicity starts showing at 5 microgram per ml. So this is the correct answer. Understood, all of you? Please tell me in the comments. Reena, HS, Utkarsh, Nimisha, Deepa. I hope all of you have understood what the question is trying to ask you, how the question is twisted. And I hope now you will not forget. Observed. That means when you first see, when you first identify, observe. Very good, Utkarsh. Very good, HS. So take a screenshot. This is yes. So that is 7 milligram per kg. Okay, here they were talking about toxicity, but I guess the units they have given wrong. The units they have given wrong here. That is the maximum safe dose of LA. Alright. In toxicity, whenever we are talking in toxicity, we talk in microgram per ml. So I think in the now I do not know what was given in the exam, whether it was milligram per kg or microgram per ml, but when we have to talk in terms of toxicity, we have to keep that in mind. We have to answer as per the toxicity. Okay, Reena? That is the maximum safe dose, not the safe dose. That is the maximum permissible dose that you can give in LA, of LA. Okay. So this is the upcoming schedule. Okay. Also, I want to tell you all that we have added new grant tests on the app. Please go and attempt the grant test. They are available with the video discussions, so that you keep on practicing more newer questions and more questions. Fine. So please go and attempt grant test. Don't be afraid of attempting grant test. Don't run away from grant test. The more you practice MCQs, especially newer kind of MCQs, the more confident you will get. Okay. With this, I'll end my session. Okay. I wish you all the very best. And thank you for joining in. Good night.